Well, welcome to the Aging Boomers. I'm your host, Frank Sampson, and of course, as many of you know, on our show, we discuss so many of the issues facing boomers, their parents, and of course, what we know is an aging population today. So I want to thank everybody for joining us, and just thanks for getting the word out. I mean, our listeners are growing, I guess you could say, organically, every single day, and it's because of our listeners that are sharing some of our shows with others, and many of you are going on to iTunes or iHeartRadio or Spreaker or Stitcher, or I would say that the greatest growth are people that are just downloading our free app, the Aging Boomers app, on your iPhone or Android phone. You can listen to the interviews while you're taking your walk or working out in the morning. And so, again, thank you so much. And I want to remind everybody that today's show is sponsored by Senior Care Authority, a senior placement and elder care consulting organization that has a national network of professionally trained and experienced local advisors to assist families. They'll work with you in determining the right path for you or your loved one and discuss various long-term care options, whether it's in-home care, assisted living, memory, or nursing care. Or if you just need an advocate, you can get advice from a Senior Care Authority advisor for your loved one. So for a free 30-minute consultation with an advisor in your area, contact Senior Care Authority at 888-809-1231, or you could go directly to the website at www.seniorcareauthority.com. So I'm excited, personally excited, of our guest here. It's a subject matter that I know little of, so I'm going to learn along with everybody. We have with us Marypat Habermas, who is a doctor of pharmacy and a certified geriatric pharmacist, certified MTM pharmacist. She has a 20-year history of older adult medication expertise and specializes with older adults. It specializes in diabetes, fall risk reduction, hospital admission risk reduction, and nursing home admission risk reduction. I guess bottom line, Marypat is, she's a clinical pharmacist who works with older adults to ensure medications are safe, effective, and optimal for individual health. So Marypat, thank you so much for joining us on the Aging Boomers. Really appreciate it.
Great. Thank you for having me.
Yeah, this is a great subject matter. I mean, I guess I just want to start out by asking, because I really, I feel bad. I'm in the industry and I never heard of this, but a board-certified geriatric pharmacist. So what do they do? How is it different than your normal or average pharmacist, I guess?
Sure. So a board-certified geriatric pharmacist is a pharmacist that has a specialty in working with older adults. In this case, geriatric refers to anybody over the age of roughly 50. And so there's a specialized certification. So as you age, your body changes, fat-water balance changes, your kidneys might change. So just as you need a specialized doctor or pharmacist for a pediatric or a small child, it's the same concept for an older adult. So you need a specialized physician or pharmacist to deal with some of those special issues that come up as you age. So the board certified just means that we've been approved by the board to carry that license. So we have to take a special exam and do a lot of continuing education to keep up that certification.
Gotcha. So your pharmacy or your business is called RX Angels. So give us a little history. When did you start it? Why did you start it? And kind of give us an idea of what that's all about.
Sure. So I started RX Angels roughly about a year ago, and the reason I started it is because I had been working in the long-term care facilities. Many people will call them nursing homes, And I kept seeing people being admitted for things that were preventable. Falls, trips to the hospital, episodes of delirium, things like that. And when I started looking at their medications, a lot of the medications that they were using were no longer appropriate for them. In fact, those studies have shown that up to 25% of medication used in older adults is either no longer indicated or it's not effective for them at that time based on their, biological shifts. So I wanted to try to get out in front of it and work more with the community-based elders rather than those that are already in a long-term care setting. So that's why I started it.
That's great. That's great. And so is it an independent, is it a separate building that people come to, and you have one location, and you're in the Minneapolis area, I think?
Correct. I am in the Minneapolis area. The way I have set up my business model is the clients can come to me if they desire, or if they are, within a relatively drivable area, I can go to them. So I can do it either way, and that's how I've set up my business. I am independent. I don't do any dispensing. My sole focus is to make sure that the medications that they're using make sense for them at this point in their life.
Gotcha.
That's a piece that doesn't get reviewed very often.
So it's more of a consulting service then. Is that right?
Yes, it's a consulting service, yes. And my goal is to reduce their risk of falling or reduce their risk of, ending up in the hospital or ending up in a long-term care facility. So I'm trying to kind of stop some of that downhill slide.
Yeah. So I don't know. Falls are just such a major part, unfortunately, of people aging, and that's a lot of people start going downhill after that happens. So I don't know if there's statistics or just your own observation, but would you say that when older adults do have falls, it's usually related to medications?
Medication plays a huge part in falls. I don't know if I can give you a solid statistic as far as how many falls are caused by medications, but I do know that medication is the primary course of therapy for most disease states. In fact, 90% of therapies for disease states is medication, and I also know that many medications contribute to falls, and the side effects of those medications are additive. So, maybe if you're only on one medication, it's not a problem, but once you start being on 3 or 4 or 5 medications that kind of all cause similar side effects, it becomes a bigger and bigger risk. So your risk goes up exponentially as you are on more and more medication.
And you would think that the physicians, would maybe know this, but is the problem that maybe someone is going to different physicians prescribing different things, and one doesn't know the other one is prescribing? What do you think the main cause for that even happening is?
Sure. Well, there's multiple causes. One is, you hit it on the head, multiple prescribers. So the more prescribers you have involved, the more risk that there is of someone not knowing what the other people are doing. But the other piece that people kind of forget about is, as you age, your body changes. So even a medication that you've been on for years and years and years, as you age, you may become more prone to those side effects. So it's really a reevaluation of everything that they're taking, of all of the medications they were on. Because sometimes, like I said, it's something that you're taking when you started it when you're 30, 40, or 50 years old. Well, now you're 70, 80, or 90 years old. That's 30 years difference of body, changes and body dynamics. So it can be even something that you've been on for a really long time can contribute to falls.
So how are you getting to those families to make them aware of your service? Are you being referred by the actual physicians, or kind of how does that all fit into kind of the whole process and that healthcare team?
Right. So that's a really good point. It is a healthcare team. They do have their primary physician. Many of them have multiple secondary physicians. And so where I fit in is I'm kind of the centralized hub. I would be the collector of data. So I get, information from the client, from the physician, from their past medical records. And, we really want to know everything the patient is taking. So even if they're taking, some kind of supplement or maybe medications that they've gotten from, somewhere else, maybe they're samples or maybe they've ordered them online or whatever, just having that full picture and then being able to communicate that full picture with their primary physician, and then any of the secondary physicians as well. So the information, the goal that we have is to really bring everybody into the same base of knowledge. And, your primary physician on average has 10 to 15 minutes to spend with you when you go. And their primary role is to do diagnosis and to come up with some kind of therapy plan. So they don't really have the time to go back in depth and really look at everything that you're currently on to make sure that all of that stuff is still needed. Right. And so that's really where my expertise comes in, as I go kind of backwards and look at everything that you're on and really ask the question of, when is enough enough? Have your goals in your life changed? Has your body situation changed? And really kind of try to dial into what you're doing right now in your life, and then what are your goals for the next 10 to 15 years of your life.
So if you have suggestions, to the family member or the senior on an adjustment to the medications, are you then communicating that to the physicians, or is it up to them?
Yep.
You're communicating to the physicians. Okay, great.
So what I do is, after they've visited with me, they will get a personalized medication list. So it lists out all of the medications that they're on, both brand and generic name, plus the reason that they're taking it or the diagnosis. And it also lists out the directions, like how to take it. Is it with food? Is it, at bedtime? Whatever those specialized directions are. They also get a personalized medication action plan. So on that plan, if it's something that they can take care of themselves, such as changing the time of a dose, or maybe it's something over the counter that's not the safest for them anymore and they can stop it, without talking to a physician. They can do those things independently. And if it's something that needs to be cleared through the physician, such as a dose change or maybe even a medication change or a medication stop, the patient or the family will get a copy of that recommendation exactly as it's written to the physician. And then I will also fax or call their physician with that information. And because the patient and the physician kind of have, it's assumed that they have an ongoing long-term relationship. At that point, after both parties have that information, I leave it up to the patient or the patient's family to follow up with that, because a lot of times the doctors kind of want to talk it through with their client and make sure that, everybody's all on the same page.
Got it. So, and again, I'm learning here with you. Okay, so
sure.
I may not be correct in my assumption here, but my assumption is that you might be brought into a situation. Something has happened, right. And you're brought in maybe after the fact, and then making that adjustment. If I'm correct in that assumption, all right, what can be done to maybe help prevent anything from happening, or that's a difficult thing to do?
So what I would recommend, obviously, if something has happened, you've fallen, you've gone to the hospital, something like that, that's a great time to try to get a geriatric pharmacist involved in your care. The other really good time to do it is on a yearly basis, just kind of build it in as a check-in with your geriatric pharmacist. And at that point, it's really anybody with at least 2 chronic conditions and anybody that's on at least probably 4 to 5 prescription medications. At that point, anything beyond that point, it's an additive risk situation. So that would be a really good time to kind of get in that baseline before something happens, because, if we can change the medication risk profile, we can maybe prevent that first fall or prevent that, trip
Right.
to the hospital or whatever. And that's really the goal.
Right, absolutely. What you're doing is quite unique, at least I think. Okay, so I know you're in the Twin Cities. We got people all over the country listening to this and go, and they're thinking, I want to consult with somebody like Marypat. Now, obviously, we'll give you, you can certainly tell people how they can get a hold of you, but if they want to, if they want to deal with somebody in their local community, are there lists of people that do what you do in other areas?
There is a list of geriatric pharmacists, and that website is www.C as in cat, C as in cat, G as in George, P as in Peter.org/locate a CGP. Now that will give you a list of geriatric pharmacists. The other option that you have is to contact your insurance company that does your Medicare Part D as in dog, and ask them if they have someone that does MTM, Medication Therapy Management. And they may have someone that, will meet with you face-to-face, or they may have someone that can offer a phone call. That program tends to be very wide. So, getting a face-to-face person, that may or may not happen. It depends on how they've set up their program. But those would be the two places that I would start.
Right.
When you're looking for someone like this. The other place that you could start is any long-term care facility does have a consultant pharmacist that comes in, and they may also know of people in the area that are doing this. They're doing very similar things to what I'm doing, but it's at a long-term care facility. So some of them may be open if there isn't anybody in your area. They may be open, to meeting with you or meeting with your family members.
Do you? That's great, and I'll ask you this again. But why don't you, as long as we're giving out websites and things, why don't you let our listeners know how they could reach you? What would be the best way?
Sure. You can find me on Facebook under RX Angels. You can also find me. My phone number here in the Twin Cities is 612-564-3658. My website is www.rxangels.org, or you can email me. You can email me directly at marypat.habermas, H-A-B as in boy, E-R-M as in Mary, A-S as in Sam, at rxangels.org.
Great. I usually do that at the end, but we were on it, so I thought I'd ask.
Sure, that's fine. Yeah.
So I'm just curious, do you ever get into conflicts with doctors on this? That you're making recommendations and they're not agreeing with you, or are they pretty open?
Usually the doctors are pretty open. They're glad to have an extra set of eyes on the profile, and certainly if there's something that I'm recommending that is reducing their patient's risk of a fall or risk of a hospitalization, they're generally pretty open to that. A lot of the doctors are not geriatricians, so they may not be fully versed in the risk of using that medication in an older adult, and so they're generally very thankful to have alternatives given, or an explanation of what might be going on with their client given. Certainly the end of the prescription chain is the doctor. So if they do disagree with me, they do have the right to say, I disagree and we're not going to make that change. And then the client at that point has two options. They can either agree with their doctor and not make the change, or they can decide, I really kind of think that, this clinical pharmacist gets what I'm going through and gets what the risk is, I'm going to find a different doctor that, is willing to agree, or think about that question as well.
Does that happen?
It's really up to the. Sometimes, not very often.
Yeah,
Usually
right.
the primary care physician is very open to suggestions and talking it through with their clients, because everybody's working towards the same goal. They want their clients to not be falling, to not be needing to go to the hospital. So, if there's something that's being suggested that can help them in that, they're usually pretty grateful that that's there. That it may have been something that they were, aware of and trying to talk through the client with them, and just having another person say it kind of makes it more of a priority, or it may have been something that they have so much on their plate that they didn't notice it or didn't know about it, and then then it's a grateful situation as well. So generally, I find that the primary care physicians are pretty open to having that involvement, and usually it's a very positive. They're thankful that someone has looked at it because it reduces their liability as well. If something happens to that client, if you can say, well, I've done everything I could, and look here, I had a pharmacist, review this, a clinical pharmacist, it reduces their liability as well if something, would go wrong.
I would think that, from a Medicare perspective or,
Mm-hmm.
insurance, that you would be a tremendous savings to Medicare. So I guess my next question is Medicare willing to pay for your services?
Sort of. What Medicare did is they gave the services of the clinical pharmacist to be paid out under the Part D as in dog, prescription plans. And so their prescription plans can take that and kind of run with it. They can do everything from like a Dear Doctor letter, your patient is on a prescription medication that maybe is not so good for them, please change it, where the patient and the doctor are not involved, all the way up to what I do, which is an hour-long, face-long meeting with that patient to really get at the nitty-gritty of what's going on, and then an ongoing relationship with their primary care team as well. So Medicare handed it off to the Part D plans, and the Part D plans can kind of go throughout that whole range as far as what they're willing to cover and what they're willing to work with. So that's why I had suggested that they talk to their Part D plans.
Okay.
It is very tricky to find out if you're covered or not because they all have different rules as far as if you were covered or not. All the Medicare Part D plans all have different rules. Mm-hmm. So it makes it tricky to find out. But you're right. There is a huge savings of having a clinical pharmacist involved. In fact, here in Minnesota, they've done a couple different big studies, and they have found everything from a 2-to-1 return on investment all the way up to a 13-to-1 return on investment. And most of that investment is seen kind of globally in the healthcare system. So it's, reduced falls, reduced hospitalizations, reduced admittance to a skilled nursing facility. But it's also on an individual benefit level as well. The patient will see, reduced copays or reduced cost of prescriptions. But really the biggest, bang for your buck for the patient is a higher quality of life. If I can get rid of some of the side effects they're having or some of the risks that they are, encountering with the medications they're on, that can be huge. I mean, that can make the difference between somebody being able to stay in their home and continue driving or somebody needing to go into a long-term care facility. It really can have a huge impact.
Sure, absolutely. So we only have a minute or two left. Maybe you could just give some overall advice to everybody, really. It affects everybody who are when they're getting prescriptions from different doctors, all right, that and those doctors may not have access to each other's information. I know there's groups that do have access, and there's technology out there that has come out, But if they don't have access to see what else they're taking, what suggestions do you have to the family member who is getting that prescription? What types of questions should be asked? And any suggestions at all?
Sure. So one of the best things that you can do for yourself or for your loved one is to really be an advocate. Have a list of the medications that you're taking and the doses that they are. Make sure you know why you're taking it, what is the diagnosis, and then the other piece is make sure you understand what the therapeutic goal is. So if any of those pieces are missing, you can ask the physician, and hopefully they will be able to tell you, the diagnosis, why you're taking it, and also what the therapeutic goal is for you for that medication. And then the other piece of advice that I would have is when you get a new medication, make sure you get those pieces. Make sure you understand, why am I taking this? What is my goal? And then also, what are some of the major side effects that I should be watching for? What's an indication that maybe this is not a good drug for me?
Right.
And then as a pharmacist, my big kind of push for the day is get a pharmacist involved. Even if it's your local, CVS or Walgreens pharmacist, get them involved, ask questions, and, really get dialed into your own health care. It's be an advocate for yourself.
Great. Marypat Habermas from RX Angels. You could go to her website at rxangels.org. Marypat, thanks so much for joining us on The Aging Boomers. It was a wealth of information.
Thank you so much. I appreciated it.
Yeah, and I want to thank everybody out there as well for joining us on The Aging Boomers. Keep up the good work of letting others know about the show, and just be safe out there, and we'll talk to you all soon.